in next few years. So in next few years, we plan to have, and maybe a surprise to Dr. Halasa, but an immuno-oncology. And so the new horizon in the treatment of cancer, and why I'm so much interested, you will look at this epidemiology and you will know cancer is the second leading cause of death. And out of the increase, out of 2 people, at least 1 is going to get cancer by 2040. 39.5% of men and women will be diagnosed with cancer at some point in their lifetimes. That was based on the statistics of 2015 to 2017. And cancer mortality was also projected to be very high. And as a result, the cost is likely to increase as population ages and more people have a cancer. As we know that it is the age-related issue, if not more or less, that old people have a higher incidence of cancer compared to the young ones. And we will be responsible for the payment in our national granted medical care. Now, if you look at the other statistics, that 2018, there were 18.1 million new cases versus 9.5 million cancer-related deaths worldwide. So that means that out of 2 people, those who get cancer, 1 is going to die. And that really stings. But by 2040, that rate even increases. They anticipate 29.5 million will have cancer, and cancer-related deaths will increase to 16.4 million, which is greater than 50%. So cancer rates are highest in the countries where population have the highest life expectancy, also a higher level of education and high standard of living. Most of the time this is true, except in cervical cancer, where the reverse is true. The incidence rate is highest in the countries in which population ranks low on the life expectancy as well as standard of living and education. So now let's look at what are the most common cancers. So solid tumors make up the 90% of newly diagnosed cancer cases. And how are they treated? They're treated by surgery, chemotherapy, and radiation. So surgery is touted as a cure, but I think it is an illusion because the residual and metastatic diseases remains a very significant issue. And breast, prostate, lung, and colorectal cancers account for nearly 50% of all new cancer cases in the United States and responsible for almost 50% of deaths due to the cancer. So you have to know these 4 cancers really in detail, because you are going to have 50% of newly diagnosed cancers are going to be any one of these 4. And if you don't provide the good treatment, 50% of all deaths are due to these 4 cancers. So one has to be very cognizant of the fact that if they want to practice the immuno-oncology, they must have to have a detailed knowledge, not about the cancer, but also about the immune system. Why? The breast cancer, most malignant tumor in women, and median overall survival rate is very low. And standard therapies which are considered in the National Cancer Index is unsuccessful in greater than 50% of patients. Tumors relapse, mortality increases. However, we doctors and patients, we doctors are not only doctors, but we can be patients too, and our patients. They are all looking for effective therapies. What kind of therapies? Therapies which are less toxic, having less side effects, have improved tumor control, and improved survival rate, improved longevity, as well as the quality of life. So now, as I mentioned before, cancer is a constant battle. Battle between the cancer cells and the immune cells. There's an ongoing fight. And if we can do something for this universal switch and can switch it to the one way where the immune cells which are fighting, we are empower them and teach them how to kill the cancer cells and win the race. And that is the goal of the immuno-oncology. We are inundated with the data, which are sometimes very biased. And this data then support the new protocols, and then having a poor prognosis by that as that they killing the cancer cells, they shut off the natural killer cells, and eventually one dies because of the total tumor burden and malnutrition and other organ failure as a result. But 99% of the oncologists are wiping out the immune system with chemotherapy. So then what happens? That they think that they are killing the single clone of mutated cells and killing them with the chemo using the maximum tolerated dose. Remember, maximum tolerated dose. That is being used in immunology, that allergy and immunology that I practiced for last 40 years. Now, this maximum tolerated dose is done to improve our immune system, because the tolerance in the immune system so that does not become very reactive. But here they are using to kill the cancer cells. They think the cancer cell is a single clone of mutated cells, but that's not so. So we are treating the thousands of clones of mutated malignant cells. However, we cannot treat with one drug because it results in a failure in greater than 50% of cases. So what do we learn? We are not going to use the maximum tolerated dose. We are not going to use the one drug treatment. We are going to use the multiple small doses. Our goal of the treatment is multiple drugs and other molecules, which may be a natural molecules, and use in the lowest dosages to kill the cancer cells and preserve the immune system. Our main goal is number one, is preserve the immune system, and as a result, by empowering the immune system, we kill the cancer cells at the lower dosage of the drugs that we are using, and that has proved in the research that they are effective in killing the cancer. We activate the immune system all the time. That's number two. And the mutations occur in all the base pairs of DNA. So whether it is genetic or epigenetic, but finally, what happens is the mutation occurs in the pairs of DNA. And if you have the blueprint of this DNA, which will be available in years to come, and one can decide what type of treatment, which drugs are going to be helpful in this treatment. And so we know that cancer is at a molecular level. Cancer has no knowledge of where it is. It may be sitting in your thyroid, or it may be sitting in the prostate, or it may be sitting in the breast. But it's no longer denoted by the organ, because after all, it is the disease, no matter where it sits. We have to look at the immune status of the patient and also the immune status of the tumor. So now we are going to look at cancer and extracellular connective tissue matrix. And some of you might have been present at the Las Vegas academic conference, and you might have seen this slide. And I'm going to show you that our body is controlled by the local ground regulation communication system, which overall health depends on the balanced, optimal, generalized homeostatic response of this ground regulation system. So it has three units of the ground regulation system, and these are the loose areolar. Here you see, this one is the organ cell, this one is the basement membrane, and this one is the amorphous loose areolar tissue, which is made of proteoglycans, glucosaminoglycans, and fibronectin, and many other elements, in particularly when we are discussing the case of cancer. But the predominant in the normal healthy people, it is the proteoglycans, glucosaminoglycans, and hyaluronic acid, and very little fibronectin. It also has this collagen fibers and elastin. And and it has, this one makes the connective tissue matrix, which this amorphous tissue is communicating system in 40% of the body tissue surrounding every cell and every organ. And it varies from organ to organ. Like skin, 87% of the dermis and submucosa of the intestine is made of connective tissue matrix. So therefore, it is very important to understand that what is the basic ground regulation system of these different organs, and how it is mutated, modified in the diseases. Then another important aspect of the ground regulation system is, there are three main connective tissue cells, which is this is the fibroblast, which is a very important, it spits out the large amount of the amorphous tissue, like what we see here, the ground substance. And also it has a cytokines, chemokines, etc. And then this one is the macrophage. And these macrophages are important because they are phagocytizing the large amount of the dead cells and materials alike. And then there's a mast cells and basophils, eosinophils, leukocytes, and lymphocytes, and all different kind of lymphocytes, including the CD4, CD8, Th1, Th2 type phenotype, and Tregs, as well as the Th17 cells. Now, the third important part is this vascular pathway, which is the end vascular pathway, which is the capillaries, and similarly accompanied by the lymphatics on the side, autonomic nerve endings, and somatic nerve endings. So many times we inject something in the connective tissue into our intradermal injection or subcu injection. The patients sometimes react so instantly. It's unbelievable that amount of reaction they may have through the autonomic response. So in autonomic response, the signal goes from the connective tissue, and one may have a neuroimmune endocrine response. So one may have symptoms in the central nervous system, peripheral nervous system. They can have cold hands, cold feet, their pink fingers turn blue, and many different kind of reactions you may get. So whenever your patient is mentioning you about having cold hands and cold feet, think about the what is happening into the ground regulation system, and what type of incitants are there which are triggering this mechanism. Now let's look at what happens in the tumor, because tumor microenvironment is very important. It has a different characteristic, and it does not play a role in the maintenance of homeostasis. As I showed you before in the previous slide, that ground regulation system is very important and it plays great role in obtaining and maintaining the homeostasis, the internal environment of the body. And tumors have a different kind of microenvironment. So their extracellular matrix is also rich in proteins, but some of these proteins are not expressed in a normal extracellular matrix in a normal individual. Extracellular matrix and blood vessels support and protect the tumor. In a pancreatic ductal adenocarcinoma, tumor is surrounded by thick stroma. So physiologically, immune cells are not able to reach to destroy tumor cells, or the chemo cannot reach, and other meds have a problem reaching the tumor. And thick extracellular matrix also keeps the T cells out, as they cannot transfer very easily. And therefore, we need the approaches to break down this fortress, which is built by the thick extracellular matrix, and meaning that we have to have some system to take care of their fibroblast. So the cells in their connective tissue matrix have unregulated growth. So what type of cells do they have as compared to our normal stroma? So stromal cells include cancer-associated fibroblast, cells of the immune system, tumor vasculature, and lymphatic system, pericytes, and adipocytes. So this network of fibroblasts, which is a cancer-associated fibroblast, represent a major cell population within this stromal compartment. They are involved in the structural and paracrine interactions between the other cells. And then what are the cells of the immune system? These are the T cells, Treg cells, B cells, natural killer cells, dendritic cells. But these have the positive, and then there are myeloid-derived suppressor cells and tumor-associated macrophages. They're also called TAMs. And soluble growth factors, cytokines, proteases are also the part of that. Surrounding stromal components, extracellular matrix can determine various phases of tumorigenesis, even conferring the acquired drug resistance as it builds the fortress. Now, this is the diagram of the tumor microenvironment. I have a better, another really good diagram, but maybe in the future meeting, I'll show you. So this is the blood vessel. These are the multiple tumor cells. And this one is the T cell, T regulatory T cell. Now, regulatory T cell has a negative impact on the immune system. It works for the tumor, it works against the survival. And these are the natural killer cells. These are the T cells, these are activated T cells, these are inactivated T cells. And these are the macrophages, as you see that. And then these are the stromal cells, which you see here. And so, as I described before, they are very tight or maybe very loose, depending upon how much of the matrix is present. Now, this is another diagram which shows you the cancer-associated fibroblasts. They are large fibroblasts. And these are all the tumor cells which are seen in the brown color. And then this yellow color is the myeloid-derived suppressor cells. And they have also negative, positive, they work for the tumor, but having the negative effect on the destruction of the tumor. And then these are the dendritic cells and cancer-associated fibroblasts. These are the dendritic cells. These are the neutrophils. These are the again, cancer-associated fibroblasts. And these blue color ones are the B lymphocytes. And these these are also the cancer-associated fibroblast. These are the parasites which you see over the normal blood vessels. But then when this blood vessel grows out, as you see that it is very kinky, and then it branches out. Sometimes there are a lot of hypoxic areas, and that hypoxia is favored, the tumor favors the hypoxia. So got to understand that if you supply large amount of oxygen, the oxygen has to reach the tumor. And if your blood vessels are not too many, then there is a problem in oxygenating the tumor, unless you are oxygenating with the hyperbaric oxygen. Now, this is another diagram of the tumor microenvironment showing the tumor in the center. And then it starts at the, we are going to start here with the antigen presenting cells, which presents the tumor antigen to the dendritic cells. And then that goes and it goes to the T helper cells. And then have some release of the cytokines. And again, transformation occurs into the polarization of the Treg cells. Now, Treg cells really have blocking the CD8 and cytotoxic lymphocytes. Now, also the mature myeloid-derived suppressor cells have a negative effect or a blocking effect on the cytotoxic T cells, CD8 cells. Mature, the myeloid-derived suppressor cells have also a negative feedback. It goes and polarizes the macrophages instead of M2 to M1, and it promotes what we need. It promotes the M2 reprogramming, and M2 is what the tumor likes, but we do not. We want polarization of M2 to M1. So remember that M1 is very helpful for destruction of the tumor. Then the B cell usually secretes the IgM secretion, Th cell stimulation, and these are the Treg cells which block the receptors on the tumor. And it has an inhibitory action on the natural killer cells. So there are many other inflammatory cytokines like IL-6, IL-8, and PGE2, which also promote the formation of the Tregs, including IL-12. This is another diagram of the tumor microenvironment, and as you see that it is just full of lot of immune cells, but these immune cells have been disabled by the co-stimulatory pattern of the immune system, which is present in the tumor. So now let's look at the characteristic of macrophages, tumor-associated macrophages, as they play a special role in cancer. It phagocytizes of the destroyed cells. It plays a great role in tissue remodeling and repair. It supports the tumor growth. Remember, it supports the tumor growth. And where does the signaling come? Signaling comes within the tumor, and that converts the macrophages from MO to M2. And it recruits the vasculature, initiates the angiogenesis. And the angiogenesis is, there are many factors which initiates the angiogenesis besides the hypoxia. And it plays the immunosuppressive role in tumor microenvironment. So in PDAC, pancreatic ductal adenocarcinoma, tumor microenvironment is rich in macrophages. And thick extracellular matrix prevents the infiltration of T cells and thus prevents active killing of tumor cells. For active killing of tumor cells, you need large amount of natural killer cells, cytotoxic cells. And not only that, but you need the activated cells to kill the tumor. Okay. So now let's look at the cancer-associated fibroblast. They are distinct from the normal fibroblast as they are derived from the heterogeneous population of cells like the mesenchymal cells, fibroblast, endothelial cells, smooth muscle cells, pericytes, adipocytes, and myoepithelial cells. They secrete proteases that are involved in degradation of extracellular matrix to promote invasion and induce metastasis. So it also secretes the tumor supporting growth factors and cytokines. The growth factors are hepatocyte growth factor, which is also called HGF, IGF-1, fibroblastic growth factor, and TGF-beta-1. These growth factors directly interact with the malignant cells to promote tumor growth. Also, they secrete cytokines like TGF-beta-3, FGF7, and CXCL12, and thereby it induces the epithelial tumor cell transition to epithelial to mesenchymal transition. And this is one of the very important facts that we see in patients with the ovarian cancer. And this promotes the invasion and metastasis. So when you have a patient with ovarian cancer, and if the biopsy report shows that there is a epithelial to mesenchymal transition, you ought to know that this tumor is very invasive and there must be a multiple metastasis. And no matter what you do, that it is very hard to bring this tumor under control. It promotes the tumor growth by recruiting endothelial cells and enhancing the tumor angiogenesis via secretion of the pro-angiogenic factors, including IL-6, VEGF, stromal-derived factor 1, and platelet-derived growth factors. And this cancer-associated fibroblast also functionally modulate inflammatory response, and thereby it mediates the innate immune cell recruitment to promote tumor angiogenesis and enhance tumor growth. So sometimes the innate immune response in cancer has an adverse effect. So there are multiple immunosuppressive molecules in tumor microenvironment. And you got to understand that this is what protects the tumor. And these are the weapons of the tumor to fight against the immune system. If you remember that's a wonderful explanation. So M1, what happens that we require M1 gets transferred to M2. Interferon gamma cannot induce its effects and proliferate the NK cells and also inflammation, and they are blocked. That effect is blocked. NK cells and that effect is blocked on interferon gamma. Then again, natural killer cells effect on the tumor is also blocked. So IDO is another component of the tumor that has inhibitory effect on CD8 cells. And Treg cells are also have inhibitory effect on the CD8 cells. VEGF, TGF-beta, IL-10, all have a negative effect, including IL-6. And here you see that the natural killer Treg cells block the natural killer cells, and the dendritic cells, so that the interaction with the tumor presenting antigen, tumor antigen presenting APC cells cannot work between them. And so angiogenesis also promoter. So these are the immunogenic cells and the large amount of immunoevasive cancer cells. And so we do not want immunoevasive cells around us. So in summary, the inflammatory cytokines of tumor microenvironment are TNF-alpha, IL-6, IL-8, and often upregulated, linked to invasive properties of cancer, which such as angiogenesis and the metastasis. However, IL-4, IL-13, and IL-10 have been reported as the promoters of an anti-inflammatory environment and adaptive immune response suppression. IL-10 and TGF-beta secretion polarizes the T cell to Treg cells. Tregs are immunosuppressive cells, and they are present sometime in a large amount in tumor microenvironment. Other immunosuppressive cells are tumor-associated macrophages, myeloid-derived suppressive cells, and they promote carcinogenesis, metastasis, and also therapy resistance. Because when these tumor-associated macrophages are very important in removing the destroyed cells, and sometimes they turn into the tumor resistance. Now, this is a very important slide for you to remember, and you can go and look at it again and again and again, so that you will understand that what are the consequences, what happens in the failure of the immune system and conquer the cancer. The immune system plays a key role in eliminating tumor cells. Anti-tumor response is often prevented by immune checkpoint molecules. And what are the immune checkpoint molecules? These are the co-inhibitory molecules. This is the CTLA-4 molecule, and this is the PD-1 receptor molecule. And they are important, as well as there is also PD-L1, which is the another molecule which is associated as the regulators of enhanced immune response. These immune checkpoint mechanisms are often activated to suppress the anti-tumor response. And this is what happens in most of our patients, that immune checkpoint have a immune checkpoints usually suppresses the anti-tumor response. And these anti-tumor response, therefore, several immune checkpoint inhibitors are needed. And they are the antibodies, peptides, and small molecular drugs. So if you have a PD-1 and this PD-1 receptor here, this PD-1 receptor has an immunomodulatory effect in killing the cancer cell. But then when PD-1 molecule, when it turns on by the PD-L1 ligand, then it is activated and it is blocked completely. And PD-1, when it activates, it suppresses the anti-tumor response. So you need the PD-1 immune checkpoint inhibitors, which blocks the PD-1 receptor. So then PD-1 is disabled. And as PD-1 is disabled, it can have the anti-tumor immune response. So it is very, very important to understand that why do we need the antibodies? Because we want to disable these receptors so that they do not have inhibitory, when they are activating inhibitory effect. So immune checkpoint, it's the molecule in the immune system, enhances or inhibits the immune responses. So co-stimulatory immune checkpoints deliver the positive signals to T cells following their binding to ligands and receptors on antigen-presenting cells. Co-inhibitory immune checkpoints deliver negative signals to T cells upon interaction with their counterparts on the APC. So they can inhibit immune responses, including PD-1, PD-L1, CTLA4, and etc. So the upregulation of co-inhibitory immune checkpoints dampens the immune response towards the tumor cells and facilitates the tumor to grow and evade the immune surveillance. So I think that this one is that very important to remember. And sometimes you need to know not only that they are present, but when there is a biopsy specimen, you need to know that how many ligands of PD-L1 were on that particular tumor tissue. And if he has a large number, then the insurance company would approve the use of their checkpoint inhibitors. So in cancer, the inhibitory immune checkpoints are often overexpressed on tumor cells, as I discussed, non-transport cells within the tumor microenvironment, and it dampens the immune system to mount an effective anti-tumor response. PD-1 and PD-L1 signaling induces the adaptive immune response in tumor microenvironment. PD-L1 is not expressed in normal cells, but interferon gamma, an inflammatory cytokine, often stimulates the PD-L1 expression on various cell types in tumor microenvironment. And that's why many times the patients have a very heavy PD-L1 expression, and you need the inhibitor to antibody for PD-L1. Similarly, PD-1 receptor on T cell acts as a dominant negative regulator of anti-tumor T cell effector functioning by the engaging PD-L1. So MHC molecules are also on tumor cells, and they play a great role also in activation of the tumor. So what we need to do is we need the immune checkpoint blockade. And this is the current most promising approach in immuno-oncology, activating the therapeutic anti-tumor immunity and circumventing the immune resistance exhibited by the many tumors. So when chemotherapy doesn't work, when they are resistant to the many other treatments, including the cetuximab, and that is the time you use the immune checkpoint blockade. Commonly used inhibitors for immunotherapy, anti-PD-1 monoclonal antibody. CTLA4 is exclusively expressed on T cells. It is a negative regulator of initial priming of T cells. It prevents the binding of CD28 to co-stimulatory molecule CD80, CD86, and of APC. CTLA4 acts early in the immune response by inhibiting T cell activation. So therefore, you require anti-CTLA4 antibody called ipilimumab, trade name of Yervoy, which is IgG1 monoclonal antibody. It negates the effects of negative regulation. So in other words, there is no suppression of the immune system. The T cell keeps on working. PD-1 is an immune checkpoint inhibitor, acts in the later stages of immune response by turning off the anti-tumor T cell response. So these are both our anti-tumor T cell response, but they act differently. Anti-PD-1 checkpoint inhibitor, nivolumab, Optivo, which is IgG4 monoclonal antibody, it negates the effect of negative regulation by PD-1 mediated immune inhibition. So therefore, the dual inhibitors synergistically promote an anti-tumor immune response by blocking complementary mechanism, and thus they restore the patient's own anti-tumor immunity. It empowers the patient to destroy their own tumor. PD-L1 ligand on APC plays a great role as a negative regulator of immune activity of T cell. An anti-PD-L1 antibody, which is known as a Keytruda, which prevents binding to PD-1 receptors and thus dampens the negative regulation of anti-tumor activity, means promotes the activity, anti-tumor activity. Now let's look at the VEGF. It is an angiogenic factor and it increases the vascular supply to tumor. Not only that, but it also has an immunosuppressive effect. It decreases the number of T lymphocytes. It activates the immune checkpoint molecules and make them more, and empowers them so that they have a negative regulation of the anti-tumor activity, meaning that it is going to promote the tumor formation activity. It increases the activity of tumor. It inhibits the dendritic cells differentiation in cytotoxic T cells. It down-regulates the MHC complexes. Anti-VEGF antibody Avastin is an anti-angiogenic agent, and it has an immunomodulatory effect when combined with immune checkpoint inhibitors. Now let's look at the immunotherapy in cancer. It is an effective therapeutic approach against cancer as it harnesses the power of immune cells and the body's own immune system to destroy the tumor. However, they are often associated with severe systemic side effects when given by the intravenous route in a maximum tolerated doses. It benefits tumor expressing specific receptors in a subset of patients. Systemic administration of such immunotherapy can result in toxicities in lungs, GI tract, liver, endocrines, and neurological systems. So now we are going to look at how can we deliver these potent immunotherapy agents in our body without causing severe side effects, without delivering them by the maximum tolerated doses. Well, we have a platelet nanoparticle delivery system. And so let's look at the platelets and PNP delivery system in cancer. So platelets have a natural ability to bind to tumors and the components of tumor microenvironment. Platelets have been implicated in tumor progression. It facilitates the metastasis by binding to the circulating tumor cells and hide them from detection, makes them more immunoevasive. Now, when the nanoparticles are delivered by the platelet membrane and they cloak it with the platelet membrane. So platelet membrane cloaked nanoparticles, when delivered by the intratumoral injection in the solid tumors, it is very effective. Plasma cell membrane of the human platelets has multiple proteins, glycoproteins, and lipids. It has a platelet mimicking properties such as selective adherence to cells in the tumor microenvironment. platelet cell membrane coating improves biocompatibility of nanoparticles to effectively interface with tumors through multimodal reactions. So when these platelets are specially prepared and where the membranes, lysate, are used, and they coat, and it enables the nanoparticles not just to bind, but be retained at the tumor site much longer than fully synthetic nanoparticles, providing greater opportunity for encapsulated payloads to accomplish their intended effect. So platelet membrane coated nanoparticles, PNP R848 in colon cancer, have been in research by the Cello Therapeutics. In that, they used this immune modulating molecule in the research to treat colorectal and breast cancer. They have been found to have effective anti-tumor response in their mouse model. When administered by intratumoral injection, PNP nanoparticles, which are also dubbed as a PNP R848, exhibited an impressive anti-tumor immune response. It is reported that concentration of nanomed platelet nanoparticle is 1,000 times higher when it is given by intratumoral injection as compared to given by the IV route. So the Cello Therapeutics have this R48 that they've been using and to eradicate the tumor and also induce the sustained long-term immunity. So mice were treated initially with PNP R848, and they were re-challenged not once but twice with increasing tumor burden.
One goes down at the same time.
I'm sorry, what? They were re-challenged not once but twice with increasing tumor burdens. They were able to completely reject and kill these tumors without any additional treatment. And this suggests that treatment with PNPR 848 has the potential to prevent future recurrence of the cancer. And this research I'm showing you is not, I'm promoting this molecule because it's not even available. But I'm just showing you that when you deliver the nanoparticle and cloak it with the platelet membrane and deliver as a platelet nanoparticle and introduce into the tumor, it is not only treats the tumor, eradicates the tumor, and sustains the long-term immunity. And as a result, when the tumor develops in any other organs, this long-term sustained immunity is what persists and takes care of the tumor, and it rejects the development and progression of that tumor. And in further slides, and I'll show you what happens. So this is the patient who had a colorectal cancer, mouse study where there is a colorectal cancer. And you see that this is the mouse which was treated with the PNP R848. And there is a 100% survival, progression-free survival. And here is the control, which is 0. And here is the free molecule of nanomedicine. And still it had a poor outcome. Then they used the pegylated, which is a little bit long-term acting, and pegylated form, but that did not have also a very high survival rate. The only high survival rate was that when it was delivered by cloaked by the platelet membrane and platelet nanoparticle, then it was very high survival, tumor progression-free survival of colorectal cancer shown in this mouse model. Now, thus, the effectiveness was established in aggressive metastatic breast cancer mouse model with the same molecule. And it significantly inhibits the tumor growth compared to the free drug and free loaded into purely synthetic particles. In addition, treatment with PNP R848 was able to substantially reduce the number of metastatic nodes found in the mice in a different places, indicating that localized administration of PNP R848 is able to induce a system-wide specific immune response against the tumor. So it was not just the localized effect, but it was the system-wide specific immune response. And it was a sustained response, as I showed you in the previous slide, that it had a sustained effect. So after a few months, even if the cancer develops, it destroys the tumor. And here it shows the tumor growth inhibition and prevention of the metastasis. So in this group, there was no metastasis. And here you see that in the tumor volume, the least amount of the tumor volume was in the PNP treated group. So nanoparticles are able to generate superior anti-tumor immune effect compared to either free drug or pegylated nanoparticles due to their enhanced retention at the tumor site. I should say not just the nanoparticle, but platelet cloak nanoparticles. So they increase their retention at the tumor site. And once you inject these PNP R848 molecule into the tumor site, it is taken up by the resident antigen presenting cells. And once taken up, it releases its cargo, which activates the antigen presenting cells. And activated APCs then migrate to the nearest lymph node, where they train other immune cells, T cells, to recognize and fight the cancer. Some T cells return to the tumor site to battle the tumor, while the others go into the circulation and surveil the body to eliminate any tumor cells that has escaped from the original tumor site. So it shows here, this is the tumor, and this PNP R48 was injected here. This is the endocytosed by the APCs, and then it goes into the resident APCs, and this is the dendritic cell, and then it has MHC2 complex where the antigen is taken, and then it goes into the natural killer cells, that naive T cell, and then it activates activated APCs, activate naive T cells. Here that this APC gets activated. Once it is activated, it becomes the mature T cells, naive T cells, and then activated T cells goes into circulation, into the tumor, and activate the T cells in the tumor. It destroys the tumor. So activated T cells are the one which kill the tumor. So here the immune system is killing the tumor, but in activated form. Drug delivery by modifying into nanoparticles and then cloaking with the natural cell membrane represents an important advancement in nanomedicine. Better results are achieved by combining both synthetic or natural nanoparticles and natural materials. The ability of PNP R848 to retain the tumor site and promote a specific and sustained systemic anti-tumor immune response is a promising step for the generalizable cure for cancer. And we do provide, we do not use any of the synthetic nanoparticles. We use the autologous platelets. We process them to the platelets membrane, and then also create the platelet lysate, and also put our nanomedicine and again cloak them by the special procedure. And then we give that either by intravenous route or by in the intratumoral injection. And then we follow that with the photosensitizing agent. We give that, we also add that to our injection solution, and then we subject the patient to the PDT treatment. Photodynamic treatment is very essential as it creates the free radicals, and a sustained killing occurs and enhances the clearing activity and immune activation. So let's look at the intratumoral immunotherapy and platelet nanoparticle. So intratumoral immunotherapy is the emerging modality in treatment of solid tumors. And toll-like receptors, agonists, are used to elicit the immune response. Effectiveness of localized intratumoral delivery of TLR agonist racemode via platelet membrane-coated nanoparticles showed anti-tumor responses. Thus, membrane coating provides a means of enhancing interactions with the tumor microenvironment and thereby maximizing the activity of R848. So intratumoral administration enhances local immune activation and leads to complete tumor regression in a colorectal tumor model against the repeated tumor rechallenges. And modulation of the tumor microenvironment occurs in by engaging the toll-like receptors and inhibiting tumor-promoting immune signaling. Among the TLR7, there is a receptor, and predominantly they are expressed by macrophages, dendritic cells, natural killer cells, and B cells. So this TLR7/8 therapy leads to expansion of the tumor antigen-specific CD8 T cells, which is important for the development of the effective anti-tumor immune response. Systemic administration of TLR agonist R848 and other members of TLR7 agonist family, when used in combination with the immune checkpoint inhibitors, has proven advantageous in treatment of squamous cell carcinoma, colon carcinoma, metastatic melanoma, pancreatic cancer, and so on. But safety concerns are there, as multiple intravenous doses or oral administration of small molecule TLR7 agonist causes the adverse events such as fever, fatigue, headache, and hypertension. Systemic administration by IV use leads to rapid depletion of leukocytes and transient local immune insufficiency. So localization of immunostimulatory agents to the tumor microenvironment can convert it from a cold to a hot state, helping to kickstart the anti-tumor immunity. And all these references are available in one of the last slides I have provided with this lecture. In order for intratumoral immunotherapies to be effective, it is necessary to confine the immune agonist payloads within the tumor site. Direct injection of free drug has the potential for systemic leakage, and that can lead to reduced efficacy. So targeted intratumoral platelet nanoparticle cargo delivery is generally designed to be antigen specific. Now, this slide summarizes everything what we have discussed so far, that we showed you the total tumor volume is minimal with the PNP delivery system of this nanoparticle. Again, the progression-free survival was also maximum with the use of the PNP molecule, coated molecule. The total tumor volume is shown as minimal. Now, this one is the specimen. And in a control mouse, you can just see that there was not much significant difference, maybe less than 50%.
Exactly. Yeah, exactly. Don't get her into a situation where you're expecting.
Reliant on that.
Yes, so in other words, don't.
You're paying, you said apartment for $2,000 a month.
Sorry,
Can I
Dr.
go?
Patel. Yes, go ahead.
So when it was treated by the free R848, free, okay, it was not coated with anything. Then again, the response was not significant as compared to the control. And then when pegylated nanoparticle R848 was given for the prolonged delivery of the this nanoparticle, again, the size has reduced. Tumor volume was reduced, but not significantly. As compared to platelet nanoparticle delivered R4048, at the same, there was none. There was no tumor. So it's very important to understand. And the tumor weight, they say it is a reduced tumor nodules, metastatic nodules were reduced. So this shows the effectiveness when you give the molecule with the platelet cloaked membrane in a nano form. It is so effective when it is delivered by the intratumor injection, which I'll show you in my case presentation. So here is a 64-year-old white male who was a retired painter, has a recurrence of cancer of head and neck, severe lightning face pain, 10 out of 10, very sharp shooting, unbearable pain, constant pain in other tumors in the neck, problem in swallowing, difficulty in chewing, fatigue, unable to sleep well because of the pain. And he was against taking any opioid, as he mentioned that it was not effective and he did not want to have the LDN not work. So now this is 64 years old white male who was diagnosed to have metastatic stage 4 cancer, squamous cell carcinoma of head and neck. He was operated in November of 2021. He was suggested to have chemotherapy and radiation after his surgery. Patient's family did some research on this treatment protocol and decided not to go for it. They were afraid of having more complication from radiation. Then they discussed this with their oncologist, who told him that he has to recommend the protocol for his condition. After listening to the patient regarding the side effects, what they have read and what happens, he said that if he fails to recommend the protocol, then he may lose his license. So that means that they are forced to tell that after the surgery, they have to go for chemo and radiation. There's nothing else that can be done. The patient was decided not to go for chemo and radiation. Now, let me go a little bit back into his history. In earlier part of the year, he had a problem, some growth in his temple area. And in this temple area, this growth continued to increase in the size. So it was seen by the physician and then was sent to the dermatologist and had a biopsy done, diagnosed as the squamous cell carcinoma. They recommended the most procedure, patient's family declined, and they used the curaderm, that is the eggplant extract from Australia. And of course, the tumor responded and growth disappeared and left this hypopigmented scar. But then after they continued all the antioxidants and etc. But then few months later, they noticed that he developed some nodules under his cheek and in submandibular area, and which completely kept on increasing in size. And then it became like a fungating mass before they went and saw the physician, who then decided to have the surgery. And then here you see that the surgery was done, and then they put the flap here. So in January of 22, he got COVID-19. He was sick for 3 weeks. Subsequently, he noted that pain was getting worse and tumor was growing back. Then he started to receive high-dose vitamin C, 50 grams twice a week. He continued to receive it, but the tumor started growing fiercely. He was, his pain was 10 out of 10, and he was not able to sleep. And they did not want to go for chemo or radiation. So they were really concerned about what to do next. And then they brought him to my office. He was started after his examination and everything, what I explained, he was given the IV artemisinin and a high-dose vitamin C, as they both have a synergistic effect. Methylene blue, ICG, are the photosensitizing agents. They were given him intravenously, and then the photodynamic therapy with hyperthermia was delivered for about 3 visits while we were waiting to get his CT scan, as well as the port, as many treatment had to be done. So following diagnostic CT scan of the chest and neck, he was started on immunotherapy treatment. He was continued on different IV therapies as well. We started him on a mistletoe immunotherapy. He continued to receive weekend IV therapies of ALA, curcumin, as well as NAD. He was receiving the polyphenols. He was receiving vitamin A, vitamin D. He was receiving the methylene blue. We started him on losartan, and we started him on LDN. So, and oral ALA, he was taking before even he came to our office. He was started on intratumoral injection of immunotherapy with PNP treatment 3 times a week. And tumors were injected at multiple sites due to poor diffusion, as was very hard, tight, and tumor microenvironment was also hypoxic. He received 1/10 of the recommended dose of nivolumab, which is the PD-1 receptor immune checkpoint inhibitor, Avastin, interferon gamma, and many other ingredients, including methylene blue, ICG, followed by the PDT, photodynamic treatment, along with the hypothermia. He also received the IV treatment of the same, and he was, as he had enlarged lymph nodes in his chest, anterior and superior mediastinum, lungs, pleura, and retroperitoneal area in upper abdomen. Within 3 treatments, his lightning pain disappeared within 10 days of treatment, because we started his treatment on Thursday. If he started his treatment on Monday, probably he would have been better by following Monday. He has received 4 weeks of treatment. Now, I would say 5 weeks of treatment, but anyhow, after 4 weeks of treatment, he is 50% reduction in his tumor mass. And in 6 weeks, after 5 weeks of treatment, he was 60 to 70% better. Now he is on the 6th week of his treatment. So let me just show you his photograph. So this is I showed you his photograph with the tumor, how bad it was. Now his tumor here in the parotid area had shrunk about 50%. Here it is shrunk in submandibular area. Then also posterior auricular area, he has a tumor which feels like cystic, but must be a very septic. And again, he had also in a supraclavicular area. So this shows his pre-treatment pictures, and this shows his post-treatment pictures. And as you see that this tumor was really prominent. This is a supraclavicular fossa, and large tumor here, and the large tumor was there. Now what you see is much more close up than what you see here. So his tumor is there, but it is much smaller than it was. And the tumor in submandibular area is considerably reduced, and you don't see the swelling like what you are seeing here anymore here. And supraclavicular fossa, it is smaller too. So now let me show you some of the articles which were there, that squamous cell carcinoma of head and neck with tumor progression recurrence within 6 months of platinum therapy was large. And nivolumab significantly improved overall survival at the primary analysis, demonstrated prolonged overall survival benefits versus the chemotherapy. Here it mentions that the head and neck squamous cell carcinoma is the most common malignant cancer of head and neck in approximately 90% of the cases of head and neck tumor. Local recurrence and distant metastasis are often observed after primary radical treatment, which this patient had. And once the disease becomes very invasive with local recurrence, recurrent disease, and metastasis, the treatment is usually palliative chemotherapy, and results are not very satisfactory. And so the new agents have been developed for the recurrent locally advanced and metastatic head and neck squamous cell carcinoma. These are the immune checkpoint inhibitors targeted PD-1 treatment, and first line gold standard is chemotherapy. However, it is not very effective. Many phase 3 studies are currently ongoing, evaluating the efficacy of combination treatment with anti-CTLA-4 with anti-PD-1 or anti-PD-L1. Very encouraging results have been demonstrated, but it is still a problem for the insurance company to accept that this is works, and you have to just keep on looking for as many new articles as possible in order to treat your patients with the most current effective therapy and not what the insurance company approves. So now I want to show you why I gave patient the artemisinin the first. Artemisinin, as you know, it is a flavonoid which is present in the leaves of Artemisia annua plant. It is linked to the suppression of C450 enzymes. However, it has also beneficial immune modulatory activity. So in cancer cells, this effect includes growth inhibition by cell cycle arrest, which is very important for the metastatic cancer, stimulation of apoptosis, inhibition of angiogenesis, disruption of cell migration, which makes the metastasis, and modulation of nuclear receptor responsiveness and downregulating the NF-kappa B. Moreover, artemisinin has a significant anti-angiogenic, anti-inflammatory, and anti-metastatic effects. Therefore, they are attractive for the cancer treatment. And another important thing that artemisinin reacts with the iron to form free radicals, and these free radicals are the one that kills the cancer cells, besides the other mechanisms. Cancer cells require iron to proliferate. And so it is more susceptible to cytotoxic effect of artemisinin than normal cells. And when the artemisinin transferrin molecule is given, it gets endocytosed, iron is released and reacts with the artemisinin, and formation of the free radical occurs in cancer cell and it kills the cancer cell. So the artemisinin transferrin is highly selective and potent in killing cancer cells. Thus, artemisinin iron carrying compounds could be developed into the powerful anti-cancer drugs. And we have found that in many of our patients that it is very, very effective. And I just want to show you one more thing, that we are targeting angiogenesis in squamous cell carcinoma of head and neck. And as you see here, this is the vascular supply, and then anti-angiogenic agents dries them up, and it just very poor formation. So, and here the immune activation occurs with the immune regulatory cell, tumor invasion, metastasis occurs here. But then when you provide the oxygenation, tumor perfusion and drug delivery increases, and immune checkpoint inhibitors, and it dies. Again, it shows the extracellular remodeling and how the tumor capillaries are providing the blood supply to the tumor. Okay, thank you for your patience, and hope you go home with some
Mario's got a lot.
pearls.
Wow, that was excellent. Can I see your references again?
We'll put them up on the, on our website when we'll have everything here. We have it recorded, and Dr. Patel, if you don't mind us having your slides, put those up also. If that's
Yeah,
okay.
Dr. Patel, I have a thing that I would like to add here. I mean, what you're doing is great, excellent, amazing phenomena. I think you're the first in the world who are able to integrate everything that's been published recently into practical patients protocols, and I congratulate you for doing that. And what we need is some ultrasound imaging. Beside, I saw that you have, it's very clear, you're able to show that those swelling of the lymph nodes are being deflated or decreased. But it will be good if we have those ultrasound imaging, because that you can have more pictures about the progress of the treatment, and also seeing the change in those lymph nodes from the solid tumor into liquid because of the necrosis. And that helps a lot to for the audience here, and also for publications to show some imaging ultrasound. But your presentation was great. If we can make those pictures and start from now, because you will continue the same protocols for this patient. But if you start doing, even with your ultrasound that you have, the small one,
Right, I will do it.
possibly can do it.
But it's just no time. You just don't know. It just Cheryl has been to my office. She knows. It's but I think I can have patient come on a weekend or something, and I can do that.
Yeah, she's got a busy hub there.
I'm sorry, what?
I said
Cheryl?
you have a busy hub there.
I mean, yeah, trafficking is not too bad, but one patient is like 10 patients, so.
Okay, so we have some questions for you, Dr. Patel.
I just want to make sure that I forgot to mention that we had used the metabolic blockade on these patients, meaning that metabolic pathways, which are common to most of the tumors, we have tried to treat. And we know that the P53 gene, we were using the rice bran extract, arabinosan, BRM4, and metformin, which is also multiple metabolic pathways. He's also on berberine, he's also on ALA, he's on Mebax, and etc.
Okay. Question is, what type of mistletoe injectable do you use?
Well, I use the mistletoe Mali when I'm doing the subcutaneous injection.
Okay. And what was the dose of methylene blue IV?
Methylene blue IV, you can use anywhere from 25 to 50 milligram. It's very expensive stuff. It's very expensive.
Okay.
It's like about $1,600 to buy one box.
Okay. What if the cancer has no solid tumors and it's blood-based or deeper tumors such as pancreatic or liver tumors?
Well, pancreatic tumor, when Dr. Halasa has a center, can be injected directly, but until then, we have to just go through the intravenous route.
Okay. Is there an IV version of platelet nanoparticle particle treatment available?
We do the both. We do intratumoral as well as the IV, because, I have to still treat his metastatic lymph nodes, although, because of the tumor burden is so high. So we cannot just rely only on intratumoral injection and thinking that that's going to take care of the sustain. I mean, they have shown in mouse model, but we don't know what type of dose we would require, what type of conditions we would require. But, looking at the clinical situation, we want to be more aggressive in the way we think that we want the dual delivery. And that would be the intratumoral injection, because his tumor load was very, very high, which was extrinsic. But what we do not see, except on the CT scan, is that in superior mediastinum, anterior mediastinum, and retroperitoneal nodes. And we want to make sure that we treat that. The beautiful part of the story is that the platelets are very attracted to the tumor cancer cell membrane. So as a result, when we give intravenously, it will seek out the tumor itself, just like the photosensitizing agents get concentrated in the tumor, which has been shown in multiple models. So this way, we know that whatever we are injecting into the patient is going to go more into the tissue that bearing the organ or the lymph nodes, wherever the tumor is. So like sometime in pancreatic cancer, that's what we do. But pancreatic cancer is a very different animal, because it's not just the tumor, but all the cytokines and the inflammatory cytokines. What it does, it induces the inflammation, and then it invades the intestines and the colon, particularly lying behind it. And so as a result, the patient develops the multiple obstructions. And to treat that multiple obstruction, the surgeons have become very, very aggressive. And then they put the intestinal stent. And if you look at the intestinal stand, it's nothing but the multiple wires put together, make it as a net and introduce there. So I had one patient lived longer than she would have usually lived, but I mean, I don't like to lose patient, but I just saw that. But at that time, I did not have a PNP treatment available. I was doing rest of the thing, but I did not have a PNP. And we see that looking at that model, that even if you supply your medicine, then in a nanoparticle form, or in a pegylated form, it's still not going to make that much difference. The tumor load is still going to be there. And as long as the tumor load is there, the cytokines are present, Tregs are there, inflammation continues, immunoevasiveness continues. And as a result, we lose the game.
Okay. Is there an IV version of platelet nanoparticle? You answered that, right?
Yeah, right.
Okay. What is your parameter to start detox in this patient?
Well, any patient, it's not like you try to, but the patient who came to me had all of that done.
Mhm.
Okay, so I could just start. But let's say that this patient came to me and nothing, he's not on anything, but he was on all 7 prongs of the environmental medicine, and meaning that his environment was cleaner. His food was clean. His son is an organic farmer. They have an organic farm, and they were drinking glass bottle spring water. So, and then he was on a gluten-free diet. He was not eating much meat. He was only on a large amount of the smoothies, different smoothies. And then the protein, he was not eating excessive protein. And he was receiving, he had a lymphatic drainage, and he was not doing sauna, but his pain was so intolerable that heat was making his pain worse. So we just could not use the part of the sauna, but they were using other methods of detox.
Okay. When you use artemisinin, should you give iron with it since it uses iron
Yes.
for its
Yeah,
function?
he usually takes the iron when he leaves his house.
And then what's the
He's
dose
out
of
of town patient. He's out of town patient, but it's about hour and a half. Sometime I told them give about 45 minutes to 1 hour. So whatever we can, but yes, he takes iron, and then we give the artemisinin. When he's not getting artemisinin, we are giving him the curcumin and ALA. So on a weekend, from Friday, Saturday, and Sunday, he gets 2 ALA, he gets 3 curcumin and 1 NAD.
Okay, and the dose of the iron?
The dose of the iron is whatever we tell him, take 2 capsules.
Okay.
I have an iron bisglycinate, and we are giving him 2 capsules of that.
Do you give iron even if they're not iron depleted?
No, not iron depleted. You can give that. I mean, cancer loves iron, so we have to be, it is like a double-edged sword. But when you are using artemisinin, you got to use it.
Okay. That's all the questions I have here.
Yeah, it activates the artemisinin, and that's the reason some of the studies, they say don't give curcumin with artemisinin because
Right.
curcumin is iron chelation.
Yes.
The other thing I think Patel experienced before with a patient, being aggressive and doing too much on the patient, you may end up with tumor lysis. And that's a big urgent case, require even ICU sometimes because of the electrolyte disturbance. So you really, when you're dealing with stage 4 cancer and you're doing those protocols, you have to be slow and then progressively increasing your dosage or your frequency, and be careful about tumor lysis.
That's right. Tumor lysis, your particularly when you give the very super high dose vitamin C along with some other other agents, patient sometimes shakes and has it's like a chills and shakes. What we have tried to do is we add calcium, and we tried calcium gluconate versus calcium chloride, and we found calcium chloride to be superior than calcium gluconate. And that has helped many patients. Again, when we are killing the cells, we want to make sure that patients' hydration is good, because you don't want kidney shutdown, or you don't want the other severe electrolyte imbalance.
Can you prevent the tumor lysis with daily IV hydration?
I think that not to be super aggressive is the go taking home message.
Okay. Okay, anybody else? Any questions?
Yeah, regarding TLR receptor, the one that Dr. Patel is talking about, it's being researched. Of course, the one that's in that company was doing it, the serotherapeutic. I mean, TLA receptor agonists or antagonists are valuable there. We're using it. Naltrexone is one of them. Thymosins are all TLA receptor modifiers. And so you can work on TLS receptor agonist and antagonist using FDA approved naltrexone, or using peptides that we are using in cancer. Did you did that thymosin alpha for this patient as well?
Yes. Yeah, I just, unfortunately, I don't know who's listening, so I had to be careful about certain items.
Right. No, I understand that. Yeah, we can confident.
It's, once Dr. Halasa, whoever is interested can really, we can put the seminar for them or something like that. So 2-day conference and go over completely all different subjects and discuss much in detail. So this is just the overview. I mean, each item can take a full hour. So this is like what the lecture I have given you can be done into 16 sections without being repeating anything. Like Dr. Bill was talking about that on testosterone lecture, 4 lectures almost repeated the same thing. But in our lecture, you won't see that.
I think our lectures were better than the AMMG ones last week. I'll tell you that. We're still waiting for the videos, by the way.
Yeah.
So, okay. Anybody else have any questions, comments?
Mario asked about training plate and nanoparticle.
Where was this? I missed that.
Right at the bottom.
Where can we train for platelet nanoparticles? Dr. Patel and Halasa, that's your study. That's your bailiwick.
Yes, that's right.
And can we access studies for PNP?
Yeah, there's enough material. You just have to dig deeper and deeper.
Okay. So Dr. Nario, you're the one who asked this. If you want, I can get you their contact information. Okay.
Thank you.
No, thank you. Anybody else have any questions, comments? Okay. Okay.
But because
What we're gonna have next week?
Well, next week I have Judge Walker's going to be here. He promised he was supposed to be here this week. We got Dr. Patel at, in the last hour, which we thank you so much for, Dr. Patel.
Thank you.
Judge Walker said he'd be here next week, and then the 29th. That's the let's see, that's the 18th. Is it? It's the next week, or the 19th? 19th, and then the 26th. Dr. Zarin and I will be presenting our first project program together. May 3rd.
I want to hear Dr. Sylvia again with physician autonomy thing, because me and her, we're going to work on putting together a company or something.
Okay.
So if she can present here again, to encourage the people about what we want to do, because it's very critical to have a firm of lawyers protecting us, defending us, providing us with all these consent letters and verifying all the protocols that we're doing and making sure that it's lined up with the mainstream medicine and with the regulations.
Okay, well, she's not on right now, so Dr. Burgess, I'm gonna have you have her get in touch with me. So May 3rd, I have Misha Berman, who's a good friend of mine. He's from South Florida. He's written a treatise on hormones. We're going to have him on May 3rd, and then so May 10th is my next open date. So we ask Dr. Cruz if she's available then with Dr. Halassa. The two of you can get together.
Yeah, because I want to have her, if she can do it on Monday for me next week, that would be great. And for you too.
Okay.
So we can have all the doctors ready for getting into our membership on moving this company forward. So, right.
Okay. So Dr. Burgess will have you pass that on for us. And anybody else have any comments, questions? Anybody else have anything they'd like to present? Because like I said, I have endless Tuesdays. So we're always looking for some speakers. So
Well, it has come to my attention that Dr. Charles Gant, who's a holistic integrative psychiatrist for something like 30, 40 years, I believe. He just completed a book that deals with elements of balancing with the nature of the earth, and basically this whole thing about regenerative soil and depletion. He's an expert in integrative functional regenerative depletion, but it all comes back to the soil. And he has just recently released a book on that. And Maria Fogarty was mentioning that he would be a great guy to have a chat with.
I think you sent me his contact information, right? So
Yeah, he's a good guy and he's always helpful. He'd fit right in.
so we'll get in touch with him also.
All right.
Okay. Anybody else? Questions, comments? We got lots of thank yous and lots of great class, Dr. Patel. So
Thank you.
you're always one of our favorites.
Thank you.
Great presentation. Thank you very much and good night, everybody.
Okay, good night, everybody. Next week, same time, same station. We'll see you.
Thank you.
Okay.
Night.
Good night.